Good evening, and welcome to the Continuous Catheters and Pain Pump Technology, What's New and What's Best Practice in 2022. My name is Heidi Border. I'm the Senior Event Planner with Azure Pain Medicine, and I'll be your host for this evening. I'd like to welcome our moderator, Dr. Jeffrey Gadsden. He is from Duke University Medical Center in Durham, North Carolina, and will introduce tonight's topic and our faculty. Welcome, Dr. Gadsden.
Thank you, Heidi, and thanks very much to Azra for hosting this non-CME webinar. My name is Jeff Gadsden. I'm a regional anesthesiologist in Durham, North Carolina, Duke University, and it is my real pleasure tonight to welcome you all to this webinar. We have with us today three outstanding panelists, and they are Leslie Thomas, who is the Director of Anesthesia at the Orthopedic and Sports Medicine Hospital in New Orleans, Louisiana, part of the Ochsner Medical Center. Leslie also attends on the acute pain service at the main hospital at Ochsner and is in charge of the perioperative medicine service for the total joint program. So she looks after all of those joint patients. So welcome, Leslie. Jerry Jones is with us as well. Jerry is an anesthesiologist at East Memphis Anesthesia Services, also adjunct faculty at the University of Tennessee Health Science Center in Memphis, Tennessee. So Jerry has a foothold in both the private practice world and academia. So he's able to offer some insights there. So welcome, Jerry. And then joining us also is Jan Bublik, who's the clinical director and director of quality initiatives for regional anesthesiology and acute pain. He's also the co-director of the point of care ultrasound at Stanford University in California. I think Jan is just dealing with some technical issues, so we'll wait for him to join us, but we'll carry on in the meantime. All right, I am going to, if we could stop the screen share now, Heidi, that'd be fantastic. Awesome, great. So tonight's topic is continuous catheters and pump technology. Now, we have, as I said, three amazing panelists and one mediocre host, all of whom practice at teaching institutions where regional anesthesia is a huge part of the culture. So we're in for a real treat tonight. Our goal is to have a discussion about perineural catheters and local anesthetic pumps, particularly what's new in both of those devices, and see what's best practice for what best practice looks like for all of our panelists. We want to make this as interactive as possible, so please do make good use of the Q&A function as we go along. I'll do my best to get to all the questions as you're asking them, and we'll save, of course, some time at the end. All right, so let's get started by setting the stage. So we have a motto in our block area. It's "Let no patient go unblocked." It's kind of a joke, but kind of not. And we all see the remarkable benefits of regional anesthesia every day. And a question that does come up sometimes with the trainees is, how important is it to extend the duration of nerve blocks? In other words, if a 12-hour block is good, surely a 2 or 3 day block is better, right? What are the high impact cases where you see a need for long duration blocks in your practice? And if someone said to you, you could only use perineural catheters to extend the duration of a block for 3 cases, what would those cases be? So Leslie, let's start with you. What are some areas where you really see the need for extending that duration?
3 cases, I would pick total knees, rotator cuff repairs, and hip fractures.
Cool. Have you got some stories about total knees that I know you're in charge of that?
Well, yeah, we're with the perioperative surgical home. We do, we send most of our patients home now, which that's kind of the big push. And I'm in New Orleans and we don't really have the healthiest patients. So frequently, plenty of them have sleep apnea and other comorbidities. So pain control is super important, less opioids and things like that. So the ability to send them home with a perineural catheter that I know is working, that allows them not to have to use as many opioids, and also multimodal analgesia is super important. Also of course, rotator cuff repairs. And then the hip fractures in the hospital, we've gotten away with not using any opioids since we do perineural, the suprarenal fasciatic catheters for them.
Oh, that's great. How are you doing those? Are you doing them, or when are you doing those in the course of
the sci-fi catheters? We are doing them when they come right before surgery. Unfortunately, we can't do it in the emergency room. That would be optimal. We just don't have the manpower for that, but we do it in a pre-op block area before they go into the operating room.
That's awesome. Jerry, how about you? What are the most impactful settings or cases or patients that you use?
Yeah, so I've been at an academic trauma center, so that's I think probably everyone's answer is going to be, what are the worst cases and most difficult you have in your hospital? Where we started is with, and just talking to the trauma surgeons, who are the patients you had the most trouble with all the narcotics and all that stuff. And they were like, oh, so these X-laps, they get a gunshot or whatever. It's an X-lapse. Like, all right, we'll start there. And that is really where we started. Started putting catheters in. Actually, it's subcostal tap catheters. Now it's rectus sheath is the best way to go, right? That's where we saw the biggest benefit is, one, a ton of narcotics they're not taking. Now they get up and walk, and the bowels come back faster, and then they're out of the hospital a whole lot faster. So they're the place where we end up using them absolutely the most, and has the biggest impact is rib fractures and that sort of thing. Those are the ones we really, when you say no, 12 hours is not enough, 20, 30, no, honestly, it's 5 to 7 days or something like that. The biggest impact that we had with many of those patients is, one, they don't go to the ICU, they don't get on the vent. And then because they didn't run into any opioid related adverse drug events or trouble with their incentive spirometry early, suddenly they're up at 2,000 or better, they're walking, they're going, and they're going home a whole lot faster. And then, you might pick the other. For us, honestly, it would probably be amputations, either traumatic amputations or amputation for whatever reason you have to do it. But honestly, the setting is more the important. I think it's not just, this is a terrible, painful thing that's going to hurt a long time. To me, it's who's the patient. So someone with a substance use disorder, or a frail patient, or someone's at very high risk for chronic pain. Those are the people that you want to go farther for. It's not, so I might put a catheter in for a knee scope in someone with substance abuse. I mean, we do single shot for adductors for our knee scopes, but someone with that sort of thing, that's a catheter, because I don't want you to take one pain pill. I don't want you, and I don't want the surgeon to say, here's 30 Percocet to go home with. So
yeah, that's a great point. Yeah, I agree. We use a lot of catheters for trauma. And the advantage there is you can do multiple. We've done 2, 3, sometimes 4 catheters. I know you have 2 for trauma. And turn them on, turn them off, titrate them down, and that sort of. Maybe I don't want to know how many catheters you put at one patient.
No complications.
But that, and the amputations too. I mean, these are patients where a 24-hour, 72. The longer you can get that block to work and keep them pain-free, gosh, the better chance they have of not having chronic pain.
Since you mentioned that during COVID, when we couldn't admit any patients to the hospital, we did, I know it was 2 or 3 semi-elective, urgent, above-knee amputations with subgluteal and FI catheters. That was the anesthetic. And we did those as outpatient surgeries. I mean, if you have a good system in place and you can reliably do what you're doing, I mean, really the sky's the limit. You can really impress a lot of administrators and things like that if need be.
That's impressive. Well, my next question, are either of you using catheters for 6, 7 or longer days?
I'll tell you, we will, not because there are problems, we will routinely change catheters out every 2 weeks. Meaning, again, these are terrible. You come in with thoracic and abdominal wall injuries. We deal with those kind of things. Then the orthopedics, then plastics. So, sometimes on the pain service, we have patients for a month or better. So for inpatients, just as a typical routine, 2 weeks, replace the catheter. I do have some stories of it going longer than that.
Leslie, any super long duration?
No, not really. We usually keep ours probably 3 to 5 days.
Yeah.
Not really going past that.
Yeah. Let's talk about catheter design a little bit, because that's something that has definitely changed over time. And so for you at home, if there's anybody out there that hasn't placed a lot of catheters, there are kind of two main designs that we commonly see in clinical practice. The catheter through the needle. So you put the needle in and then thread the catheter through that and then take the needle out. And then the catheter over the needle. It's sort of like a big long angiocath. You put the IV and then pull out the stylet. And so those are and I know Jerry's prepared a little demonstration of both those technologies. So you want to share those with us, Jerry?
Yeah, I could do it now. I could do it later when you talk about, yeah, I was going to just talk about two or a couple of tips and tricks, because a lot of people, I mean, the prevailing feeling is, look, I can barely get over there and get a single shot block in with all the setup and stuff and the dressings and the follow-up and all that stuff. And it just takes too long to do. And then heck, half the time the catheters fall out or they're not in the right place anyway. It's too much trouble. So I wanted to share a couple of tips. I wanted to use it with my ultrasound, but I think that it's going to be too bright. It's not going to look right. So if you can bear with me. So again, what people will say is, you go, here's your probe, you stick the needle in and you inject. And then when I want to put the catheter in, I've got to set the probe down and go get the catheter and thread it in there. And then invariably it goes to the wrong place or this and that. So what you really want to do is be able to put the catheter in there under real time. So when you talk about features that I particularly like, you can see in this particular one, if I can hold it up close enough, it's kind of notched here. So what I do is I'll get the bolus in, and this is a catheter through. So I'm going to push it down to the end where it's just starting to come out, right? So I know where it's coming out. And then I hold it with those two fingers. And you can't maybe do this on the first try, but you can get it after that a little while. But then with these two fingers, I just put it in. So then once I get the bolus and I make the little pocket like I want, I put it where I want. And then I thread the catheter as far as I want and put it in the right place, right? So that works a lot of times. One of the downsides of catheters through needles that if you don't have a superior sort of dressing, they tend to leak and things. So that is, we're talking about the design. One of the advantages, I think two of the main advantages of the catheter over, and this is another example of one, catheter over needle, is when you put it in, the catheter is big, compared to the hole you did. So it's not going to leak as well. And it's what a lot of people who are doing single shots are accustomed to doing. There it is, go to the spot, inject the stuff, pull the needle out and done. Well, this one, I was saying, you just leave it where it is. And then you do the same in this case, you would pull it out. And, this one has an inner cannula sort of thing that extends out a little beyond. So then you're there. So getting that to work well, though, it's important to make sure you get into the space far enough. So I'll just tell you one of the tricks that I've come across, and it's similar to the other. So let's say if you're doing an inner scaling, I'm just going to leave this out of the way. So here are the roots, and your needle is coming up to. So what I'm saying is, if the issue will happen is this, I'm right up next to them. If I leave the catheter right there with, say, the middle scalene muscle here, I've put some local behind it, so I've got a little pocket of local. So I can leave the catheter tip essentially right there. The problem is when that dissipates and the muscle pushes up against it, all of a sudden my catheter is back in the middle scaling, right? It happens in other circumstances. So what you would want to do is advance it farther, but you don't want to advance towards these nerve roots here. So what I did once I put the bolus in, just kind of push the tip forward a little. So now, it's not sharp whatsoever. And I've created that little pocket, and I can push that into the pocket. Now I can lead the catheter into the space a little farther. And just like I kind of put slack in with the other, that would go farther, I would just push it. And then sometimes then I'll even this is not too hard once you've disconnected. Just push it off a little farther too. And this is really your final destination, right? So there, then you slip it in there. You wouldn't want to have it where just the tiniest bit of this catheter is sticking through the other side of the middle scalene muscle, because as it goes away, it'll pop in here where the patient just moves a little and then it's out of it. So those are both techniques that you can do with just your two hands and in real time do it. So you're holding the probe, you've got the needle in these two fingers, and then you're advancing it with these two. I mean, an assistant who might be there can hold the probe for you too, but those
Yeah,
are
I was
just
gonna say assistants. I'll have a nurse like hold the probe for me if I'm concerned about that. For people out there that
Mhm.
don't have that specific catheter or just interested in, you can have somebody else hold the probe for you sterilely as well.
Right.
Yeah, we should have been born with 3 hands to really take the catheter properly. But yeah, those are great, both great suggestions. Have someone just put their hand in there, hold that probe steady while you can guide that catheter in. Cool trick about the inner scaling, about threading that down the groove a little bit further. There's a version of the eCath that has the inner stylet sticks out even a little bit more. So you place that cannula and then the inner stylet sort of goes another couple millimeters.
I actually have a question for you, Jerry. Are you using those for total knees?
I think, yeah, I mean, I tend more often to use the catheter through the needle, but I mean, I really say that sort of is this Chevy versus Ford. If you do an art line with the thing that you push it through, or you do the one that's like a catheter over, you can do either one. I think that you just have to be thoughtful about, especially if you're doing an adductor. You don't want to push into those multitude of nerves that, with the relatively sharp needle. So pop the thing over and move in. So I think, without going into a long discussion, absolutely. And I assume you're doing adductors.
I was just asking because like some of our surgeons use a tourniquet, and having that connection underneath the tourniquet, that was my question about that.
Oh, I mean, I think you bring up, I think, a very important point. So we would have those same kind of things. Well, the catheter's in the field. So a lot of times we do the single shot block ahead of time. When they're comfortable and happy in the PACU, you want to have free time, bloop, put it in. Or there'll be the certain surgeon says, well, I need to do a neurovascular exam afterwards.
Right.
Put the catheter in with saline. As soon as they do their hand like they want, immediately bolus it. And you're not trying to get a half awake, half sleep, really hurting, bandaged person under halfway.
So that's a good question, Leslie. It brings up the idea of, are there certain blocks that are better suited to the catheter over needle versus the catheter through needle? Is that any particular things that stand out for you that are winners for the catheter over needle design? You don't have to pick any if you don't want to.
I was going to make the point that I think some of the things have to do with relationships with surgeons. So yeah, tourniquet's an issue. I mean, you can't have a hard plastic thing in the way. You can certainly adjust your technique so that you can't come in from a different thing, whatever. Without that, sometimes what we've done is put the catheter in sterilely, leave it all under tegaderms and whatnot. And some of our surgeons, for example, our burn surgeons all the time, they'll just prep that into the field. That's not an issue, but that is an important consideration about the tourniquet being in your way.
This brings up the issue of orifices. Not a question you get asked every day, I'm sure, but are you a fan of single end hole versus multiple side holes at near the end of the catheter? Do you think that makes a difference, or?
I do. I'm using the multi-orifice spring wound catheter, and I do a lot of intermittent boluses and patient demand dosage. And I want those 3 holes because I feel like I get better spread. And we do a lot of erector spinae plane catheters as well, a lot of plane blocks. And then, the other adductors and interscalenes, and we can get in this later about the amount of local, but we're using a lot less local. And I think having the advantage of the multi-orifice, you get a better spread of the local anesthetic using less amount of local, if that makes sense. And I've really seen that clinically.
Yeah.
My experience is that, I mean, either one are fine. But I have found that the single orifice, the open end, I think you're right. If it's open end, it's going to shoot it all that way. The holes, you're going to keep it closer to where you are, and they're going to maybe go in different directions or something like this. But I can say with great confidence, some people, I think they want a whole lot of holes, maybe because they're not sure that at least some part of the catheter is where it's supposed to be. Maybe that's a consideration, but I think what I have found is even when you thread it a long way, you always have backtrack. I mean, so, like we did one that connected the, like a subpec connecting to a rectus sheath for a sternotomy and X-lap. It kind of went through the rectus sheath and landed in the rectus sheath on the farthest on both sides. And it did, the end of the catheter is in the rectus sheath. And of course it goes all the way down, but it backtracked up to the chest. So I don't think you have to do one or the other. And I can say, if you can be successful with either one. There was the one catheter that had holes all the way along it. Yeah. But then you get most of your local anesthetic, and you get a lot of your local anesthetic in the wrong place.
Got a question for Dr. Thomas. How long do you keep nerve block catheter in for total knees? Is it the adductor canal block, and any mobility issues for physical therapy?
No, that's a great question. So we normally keep them in about 4 to 5 days. And a couple of years ago, we used to run a continuous infusion, and we ran pretty much everybody about 8 cc's an hour. And then we started noticing, especially for the same day surgeries, to get them out earlier. So we started rehab on the day of surgery. We had some patients with quad weakness. So we started looking at that. And so we adjusted it based upon patient height. So it depends, on their different height, and we lower the rate to either 4, 7, or 10 with intermittent boluses. And that usually with the volume with our electronic pumps that we're using, we've actually had to decrease our VTVI on the electronic pump because our surgeons don't want the catheters to last more than 5 days. So like say for a total knee, a patient that's under 5'4", we run that at 4 cc's every 3 hours. They get a demand dose from the actual pump or intermittent bolus, and the patient can actually give themselves a demand dose. We had to turn off the VTVI from, it was 500 to 300 because some of these would last for 10 days. And it works really well. We put them in the adductor using the multi-orifice catheter. And we actually have a whole process about leakage and all that. I know that's a whole nother thing that we used to actually have more of that when we used an elastomeric pump, and we don't seem to have as much as that, but we use Dermabond and different techniques for that. And we can go into that if y'all want, but we're not seeing as much leakage either.
I do want to get into that about how you keep your catheters in place. But before I do, it's really interesting about how you adjust for height. I've not seen that before or thought about that before. Have you come up with a nomogram that you use?
Yeah, we looked at, we had probably 15 to 20 patients, and it didn't seem like a lot, but I'm in a 8 OR hospital, and it's basically they're trying to get everybody out, and we're under the microscope. And so the surgeons were like, we have quad weakness. So we had to look at it, and we saw it was all dependent on patient height. So we just kind of did that on our own, the 4, 7, and 10, and it works incredibly well. It's shocking how well it works for a very small amount of local. Like 4 cc's every 3 hours is not a lot for an adductor, but we're also regional anesthesiologists. So of course they're impeccably placed people, just. But anyway, so there's a little technique involved. But yeah.
That's speaking of technique, I have another question here from Dr. Aurora. Where exactly are you placing your adductor canal? Is it mid-thigh? Is it a little bit higher, a little bit lower?
Ours are, well, I'm sure everyone in the group does it a little bit different. And I would just piggyback on what she just said a minute ago is your average patient, yes, 2 really or 3 days is kind of what you need with really terrible. When we have special patient populations, we will aim for 5 to 7. So, your regular person coming in, especially those coming in for an outpatient total knee, you need 3 days or something like that. I totally agree with that. And ours, femoral triangle, I'm really looking more where I see the artery here. I'm better at drawing pictures than describing it. There's the sartorius. I can clearly see the artery under, and I can see the, the white horn of, all the rest of the nerves. And if I have any questions, we've been pretty lucky about quad weakness, but instead of just like going straight across their thigh to where you're at that relatively high point, I tend to just point my needle towards the knee a little bit. So maybe that first initial bolus and or catheter location is going to be headed that direction. So it's,
yeah, that'll kill your catheter program pretty quick for your knees if you start getting a lot of quad weakness, for sure. But I do think there's some advantage to blocking the adductor canal a little bit higher than mid thigh too. I think you just get better results personally. But another question: other blocks for knees apart from adductor canal? Not really related to catheters, or maybe it is. But just quickly, what do you got? What's your total knee package look like?
Leslie, you want to go first?
We get definitely multimodal analgesia. Everybody gets a gram of Tylenol and 400 of Celebrex pre-op unless they have any sort of renal issues. We do an adductor catheter, and we usually use 15 cc's for that, and usually put around 5 cc's around the nerve vagus medialis, then put the rest around the saphenous, and kind of thread the catheter with the multi-orifice catheter. So it's kind of getting around both of those, if that makes sense. I know that people like the IPAC. We used to do the IPAC, but we did a prospective randomized study, and we found really no difference with multimodal analgesia. I do think that's a big thing. So we only do IPACs, which is the interspace between the popliteal and the posterior capsule of the knee. For those who are not sure what that is, it's for the posterior pain of the knee. We stopped doing that because we didn't really see a difference after the PACU. And so we only do IPACs if a person has sleep apnea or chronic pain or something, we're concerned about that. And then we send them home with the electronic pumps connected to the adductor catheter, but then multimodal, consistent Tylenol, immediately oxycodone if they need it in the Celebrex.
Leslie, can I ask you on top of that, do your surgeons use joint juice?
No.
They're injecting a whole bunch of extra stuff?
No, they're not. They're not.
I like that term, joint juice.
So there's 10 different things, and
talking about the IPAC, Leslie, Dr. Tannenhill has asked, is anyone using IPAC catheters for multi-ligament knee reconstruction, ACL, PCL, MCL kind of stuff? I've not done an IPAC catheter.
For an ACL or an IPAC catheter?
Yeah. You guys...
I do have to mention, y'all, before I forget, one of the other reasons we don't do the IPAC as much is because we had some foot drop, which is, perineal nerve functions issues post-op. And the surgeons were thinking it was possibly related to that, or even the adductor. And that was one of the other reasons. Pardon?
It wasn't the tourniquet.
Right. And then the kind of funny thing that one of the surgeons that blamed us started injecting in the capsule himself, and he's had a couple foot drops. So we could just kind of giggle on the side about that, by the way, just FYI, but yeah.
Well, because they're doing it blind, right?
Exactly. Yeah.
Yeah. I keep telling them seeing is believing. We have ultrasound. We can do it precisely.
Jeff, let me ask you something. You and I had a conversation some time ago, and we were talking about total knees and things, and you were talking about specifically taking time to identify and or go after the genicular nerves. Is that something that you do?
Yeah, still doing it routinely.
What do you guys? I assume Duke does some regional anesthesia. What do you guys do for? I'm sure everyone wants to know what they do at Duke.
Big hammer, little hammer. So we get adductor canal. We'll do an IPAC as well routinely. I do agree, Leslie. I think if you held a gun to my head and said you got to stop doing one block for the total knees, IPAC would probably be the first one to go. But it does, for some reason, it does seem to do a little bit with mobility for some reason on our patients that first day for whatever reason. And the geniculars. So I'm a big fan of geniculars. We published a study last year looking at genicular blocks with 0.25% bupivacaine versus placebo, and found a 60% reduction in first day opioids. So those are the nerves that you're missing with adductor canal and IPAC. So it's a way to sort of, I always think of it as reconstructing the old school blocks that I used, I got enough gray hair, you can tell. Back in the day, I used to do femoral catheters and single shot static blocks for knees.
Yep.
And let me tell you, if I come to your hospital and I have a total knee, that's what I want. Anyway, so that adds a little bit extra. So I am a fan of catheters. Speaking of tourniquets, you guys mentioned that a second ago. What do you have any strategies for keeping the catheter out of the way of the tourniquet, or how do you address that issue if you're doing the catheter ahead of time?
I'm not concerned at all with the tourniquet because not all of our surgeons use tourniquets, but they have the tourniquet up and the catheters underneath it. And we haven't really had any issues. Mind you, we put Dermabond at the side and we put steri strips and things like that to make sure the catheter doesn't move. But originally years ago, I was a little concerned about that, but it just hasn't really panned out for me and our practice. We haven't really seen the issues with that.
Right. I agree. Same thing. Unless you have some little, hard plastic thing, just the catheter underneath. I've never, hundreds and hundreds and hundreds, never seen issues.
Yeah. There's a theoretical issue that we also struggled with, what if this is happening, but it never seemed to be a thing. I want to switch gears a little bit and talk about pumps and pump functionality. So program intermittent bolus, the ability to deliver this bolus of local anesthetic at a certain interval, seems to be, to me, one of the big selling points of these electronic pumps. How are you finding that's working for you? What are where are the wins there?
I say the huge part, we decided when we finally switched from a continuous dribble in sort of thing to the pulse dose, we decided initially to go with a Q3 hour intermittent bolus regimen. And in the end, that made the math incredibly easy, because basically anything that we would run at 12 cc's an hour, 10 cc's an hour, 8 cc's an hour, it was 12, 10, 8 every 3 hours, no difference. Which again, in the trauma center, when you've got lots of catheters and things, it was revolutionary. Plus, instead of guessing if they were going to be okay in about 2.5 days when just a balloon or something would run out, these things, because you have so much more length on it, instead of kicking people out 2.5 days early, I'm kicking people out 5 days early. It's a game changer.
Yeah, I agree. The predictability of it, when they're going to get it. We did have a few issues with our elastomeric pumps, and the surgeons were telling us that sometimes the patients would say after 24 hours it was gone. And then on the converse, we had patients that they were always concerned because the ball never got smaller and they thought it wasn't working. So we would get more phone calls with that. So the nice thing about these electronic pumps is we know exactly what's being delivered. The other thing is the ability to do these PIBs like Jeff mentioned. And the other thing is we send them home with a demand dose, and patients like having that demand dose. I think we get a lot less calls because of that. And we show them how to do it. And especially if they're hurting right post-op, because that does happen, and then they see actually after they press it and they get comfortable, they are a lot more comfortable going home after that, knowing that if I press it, I'm going to get more comfortable. And that's, I think, allowed us to have those much lower doses than I ever thought would have worked with these electronic pumps. And then with the one we're using, we limit the volume, but if you wanted to, kind of like what you mentioned, Jerry, you could change out the bag with the electronic pump and just hook up a new one. Whereas those elastomeric pumps, you have to get a whole nother one, and the expense of that was more. And we really like it a lot. The electronic pumps, and the surgeons absolutely love it. They love it. They've told me like shoulder surgeries, their patients don't really use opioids rarely now. It's incredible with shoulder surgeries, incredible to me.
Yeah,
That's awesome.
I think it's even what seems like a small thing, the electronic thing that shows, because we'd run on most people, just to keep going, a basal rate of like 1 cc an hour, but the patient can see that the thing clicks and clicks and clicks. So that maybe I am doing okay. Maybe it's not, because right, they can't tell the ball's different or it's whatever, but they can see it. And then know when they hit the button, they hear it make a noise. It does a thing. Oh, and I feel
Yeah.
better. That's huge.
Yeah. We used to get calls on that first post-op day. Hey, the ball's still hard. I'm like, yeah,
Yeah.
it's probably going to be that way for the next, 12, 15 hours. And then, but I agree that reassurance that, oh, something's actually happening. And Leslie, your point about that satisfaction element to a demand bolus is huge. It reminds me of all those OB studies with patient-controlled epidural.
Yeah.
Same local anesthetic regimen just gave them the satisfaction of controlling their own.
Right. And I think it also, the patient bolus on top of that, because some catheters, they're perfect. It's just right. It's whatever. Sometimes they're not. So that kind of gives you some fudge factor. If maybe you need the extra, but pulse dosing, it covers it better. I think we've seen that the literature supports that. But the catheter that's perfect, sure, they don't hardly need it so much. But being able to push the button a few more times, it's amazing to me still when you can guess how much you think somebody needs for the infusion. Surgery X, patient Y, 10 cc's an hour. Sometimes at 10 cc's an hour, they're miserable. But if you can just make them 12 cc's, they're totally fine. So that little bit of extra that they can get, it makes a world of difference.
Getting back to the changing the bag comment that you made, Leslie, Viv Ip from Edmonton has asked how and who changes the local anesthetic bag for the ambulatory pumps for these patients while they're at home. Are you changing them at home, or are you, because you said earlier, like you actually had to reduce your volume to be infused number on the pump because otherwise it would last for 10 days.
Right.
And then how much volume does the local anesthetic bag contain at your institution?
Ours is 500 cc's. So for the 4 Q3 hours with the 5 demand every 30, the VTBI is 300, and then there's the 7, and then the 10, it's 400 and 500. We've not had to switch out the bag, but we've had patients come back, and we've done it a couple times where we can actually literally just change out the bag. It's really super easy with the pump, and just reconnect it, and everything stays sterile. It's very easy, but we don't routinely do that at all. I've done it a handful of times.
Right, and that makes sense. So at a trauma hospital, there, we're keep getting people out early, and it's something that's going to last a long time. So our capacity is either 500 cc's or 1,000. The pump that we use, it'll run for 10 days or 1,500 cc's. So, if 500 is going to end up being enough, the 4 or 5 or whatever it is days, great. But if we think it's going to be longer than that, then we'll go ahead and put them on 1,000. And we even have a splitter thing, so that you can put 1,000 cc bag in there, and then it's on the catheter that comes out of the pump. It's just a little device that splits it. It's not absolutely 50-50, pretty much. So if you have bilateral mastectomy, there you go. Same patient though, we might give them 2 bags that are 500 or 1,000 each. If they had bilateral rib fractures, the left is really, really bad, so that one's going to be at a higher rate. The right side's bad, but not as much. We'll put them in on a lower rate, and so that left side, right side. So it gives us a lot of options.
Mm-hmm. One thing that the literature seems to suggest about the programmed intermittent bolus is it gives equivalent or sometimes better pain control while using equal or less opioids, but also reducing dramatically the amount of local anesthetic you need to use.
Oh, for sure.
It seems like a safety aspect that is being overlooked sometimes. Is that important to you?
Absolutely. Yeah. I mean, I knew it was going to make the overall use lower, but I mean, it's a third as much. Just about everything that we do, whatever you would run, it's a third of that. And that is a huge, again, especially if you have several pumps running on someone. It's huge.
Yeah. And then with all the plane blocks needing a larger volume, I think it's so important.
Mm-hmm.
Yeah, I agree.
Right. And that's, I think that's one of the problems with the infusion is, again, if you inject local through an 18 gauge needle, with it kind of shoots all the way over there. If you just try to bolus it through a catheter, it's tiny. It's dense right where you are. That's why you really need the hard push all at once to spread. So you put, say, rectus sheath blocks or single shot or catheter, whatever it is, the patient's going to be comfortable when they start waking up. But when that puddle gets smaller, it's not that the whole belly is hurting. It's the very, very top, the very, very bottom, or both, but they're going to ask for narcotics just as much. So having the thing that kind of pushes it farther, or if it, I don't know, goes up and down particular nerves, and so it turns off more nodes, whatever it is, it's absolutely real. End of story.
Yeah, I will say one in our inpatient population for our hip fractures, we do supraangular fascial catheters. And so we're giving them actually a 20 cc every 3 hours, which we're still kind of playing with that. But we actually have changed out the bag on that. We don't use the Nimbus pump, which is our outpatient pump. We use a different one, but we do have that flexibility, which is nice to actually change out the bag. So we can extend that for 5 to 7 days, which for hip fractures we normally do, which that kind of answers your question about that as well, Jeff.
Yeah, you bring up a good point along that lines. We did the same thing. We have a pump for inpatients, and then okay, now you're getting home. We give them the Nimbus pump, and I mean that's our system. The hospital already bought these pumps, so there they are.
Yeah.
But the problem is, like, you're here overnight. I just got you acclimated to this pump, like, and I'm going to tell you about a totally different one. Like, one system would be,
Do you think with the it's interesting here talking about the program bolus and then the demand bolus, do you think we're talking about continuous catheters? Is the continuous part dead? Do you still use a basal rate, or do you just eliminate that?
No, I think the only place that it really stands out is that I have seen that matters is interscaling. So, you're too close to the phrenic and, the sympathetic. So if you do a program, if you say, I'm going to do this every 4 hours, everybody's going to have, I think that is one time where just a little bit, or it's a very small intermittent bolus that you use, is the way to go, because otherwise it spreads away from where you want.
We actually do ours 7 every 3 hours, and we have not really seen it. And I was actually very surprised. I actually was concerned about what you're saying and the hoarseness, and we just have not seen it. And I'm happy. I've not seen it.
Yeah, that's something that we learned sort of the hard way too, is that, our instinct initially was this, okay, we'll give the same volume every hour like we were before, but we were overshooting by a huge degree. So we could definitely back off to Q2, Q3. How about double fascial plane catheters like ESP or rectus sheath? How are you programming the pumps for that? Are you same time? Are you alternating the boluses so they're going at different times?
We've had especially big things where when we have, we'll alternate them. So you get yours, the catheter on the left is going to go at noon. The other ones are going to go at 1:30. We have had a few incidences, minor, toxicity. They get ringing in their ears or something's a little weird, just reprogram or something like that. So with using a lot of them, that's actually what we do. That's our strategy.
What kind of rates are you running with that? I'm just wondering from my own education.
So, I mean, again, it depends on what the injury is, but if someone has an ESP for left-sided rib fractures, 10 to 12 every 3 hours, maybe 12 to 14 if they have a lot that are, really far apart. If it's just a thoracotomy, maybe it's just 10 or something like that. And I'll just mention that too. We just throwing in my experience, I know that paravertebrals must be a lot better than ESP. They have to be, because so we would have people with rib fractures and, oh no, they're going to have a thoracotomy. Well, you got to pull that ESP catheter out, put in a paravertebral, and there's no air in it. It's going to be easier to see. And just sometimes we've just gotten too busy and this and that. We've bolus people's ESP catheters. They do basically the same as with the paravertebral. I mean, catheter has to be in the right place, but just making that side point as we're talking about, best techniques or best practices and things. We assume that you would have to have a paravertebral for something awful like a thoracotomy or sternotomy. ESPs work.
Oh, ESPs, yeah, I agree.
Yeah. It's taking a lot of heat, but
different pro-con session.
Yeah.
Hey, are you using a delay start function? So you've given a bolus of local, the catheter's in place. these electronic pumps allow you to say, hey, I'm not going to start my infusion for 6, 8, 10 hours because I know that bolus is going to keep them going. Are you guys using that function at all?
I am not. I'm not at all. We're using 1/4% ropey for our initial block. And we've done on the purpose so that they don't have a huge drop off when that initial block would wear off. So we're, doing a general on top, but we give them a bolus once they get to PACU, just so that everyone knows it's working and all that stuff. And the patient sees it when it's going in.
Mhm.
I think I think it's a great feature. I think the practical thing is, and again, why I like electronic pumps over elastomeric. You can hook somebody's elastomeric pump up and it looks the same. It might look the same in 3 days because there's a little kink here or there. I like something to have been bolused in before they leave the hospital. Then I can say, oh, hey, there is a problem. Oh, wait, here, this little thing, let's fix it right now. I don't want somebody to go home to find that. And it's not as big. I mean, it's not as big a deal when you know your regular surgery patient who needs 2 or 3 days. The bag will last 5 days anyway. So,
Yeah.
I mean, it's a thoughtful extra feature, but one, I want to make sure that I know it's functioning before I send them out, and they last so much longer. I don't necessarily have to utilize that.
Mm.
Have you all had any issues with the alarms going off? Because that was something I was a little concerned about before I did electronic pumps. And we have not had that, but I know that's a question that some people will ask. Have you all had that at all? With the alarms going off on the electronic pump? Yeah, we have.
I think, again, this what goes into the keep 1 cc. You have to, you don't want to have 60,000 recipes for all of it. You want to have them compacted down to just however many you need. But what we found is if it got within 1 cc of, hey, you're about to hit your limit, the light would turn red. It's still going to do what it's supposed to do, but it just alerts, it concerns patients who get calls. So that's the only real alarm problem, if you want to call it an alarm.
We were the only one we seem to hear about, and it's not actually that often, is the occlusion alarm, so the kinking. Mm-hmm. But what's interesting is that we use an Nimbus pump, and it's got a built-in sort of pause. So if it detects an occlusion, right, it waits for the patient to kind of like roll over in bed, which is usually the problem, and then it goes away. So it doesn't automatically assume. It's like an Alaris pump. As soon as there's an occlusion, it doesn't happen. So once in a while, a patient will say, "Hey, it was beeping," and then I just sort of like moved the pump a bit, and it went away.
Yeah, you're right.
We had the same concern though. We're like, oh, is this going to be? It's going to add phone calls.
Right, that's what I was worried about. I really was.
You brought that back to my team. We've had that. But you're right. The good news is it'll push. It'll get a cc or a couple in, then it beeps and stops. But then it presses on. Then it goes, and it might beep again. And again, one more reason I like to check what's going to happen with the bolus before they leave the place, because sometimes flushing and changing and finding a little thing will fix it.
Hey, one more thing about the electronic pumps. I like Jeff kind of mentioned, we have all our specific programs. They already programmed into the pumps, so it's super easy for the nurses to set them up. And I also think that's a safety thing. And I like both of those things a lot about electronic versus elastomeric as well.
Right. You can do some unusual, weird, like we've had something, it's an awful surgery, heterotopic ossification. Let's get him through this for the long bolus. And he's only going to go to physical therapy every other day. Well, then that's a unique program. And I'll give him, something very low in the background because he's usually okay. But when I go to physical therapy, he'll get some enormous bolus. So he just have to hit it like 6 times during the day to get caught up. But you're right. I absolutely agree with that. You've only got a few choices. You're not going to accidentally put in 100 instead of 10. It's pick that off the library and done.
Yeah. Have you got yours labeled like interscaling, adductor, that sort of thing?
We just have the here's what your rates are. And then everyone knows, like, oh, for your standard sort of things, this is this one, this is this and this and this. Honestly, in the trauma center, lots of things are sort of unique. So, you know, we don't have them labeled as here's the adductor for a total knee. Here's the distal radius. This is the whatever.
We actually do, because ours are mostly, we're not doing a lot of trauma at Ochsner where I am, but we have a 4, 7, and 10. And the adductors, like I said, depends upon the height. Interscalenes, we do 7, and infraclaviculars, we do 10. Popliteals will do 10. And those are the main catheters we send home. Now the supraanal fascial catheters, that's a different pump. That's a Sapphire pump, but our outpatient catheters are the same, the 3 different ones, regimens.
Mm-hmm. What do you guys do, Jeff?
You know, with our library, you mean?
Right.
Yeah, we have we use that library quite liberally. So we made a bunch of I think we have about 20 different programs just to, yeah, I mean, just to, so allows us, like you said, Leslie, just to, all right, this case, I want to press this button, and some of them are for like dual catheters, and some are for, we're doing them in kids now. So we had to develop a whole pediatric library for different weight classes of kids and that sort of thing. So a couple of questions here about stimulating catheter. Are you guys using stimulating catheters at all?
No.
We do when we do just the regular, the old Labat, you know, approach for the sciatic nerve, because I can't see that under ultrasound. So yeah, we'll use it for that. And then the residents can actually use a nerve stimulator and a nerve, you know, stimulating catheter, which they need to do, right, Jeff?
Right. Yeah. Right. I think using nerve stimulator as a additional safety or what, I mean, ultrasound is the answer, but there are times and circumstances and whatever where it's reasonable to have that on. But stimulating catheter, that's the other problem that would have is, again, with a trauma center, there's all kinds of, oh, they also have a dissecting carotid artery. Did you, you know, I don't want any metal in anything. I would like the catheter to be visible under ultrasound. That's convenient. Again, watching it go in or pulling it back, or did it move or something like that. But we'll always stay away from anything with metal in it.
Here's a question from Dr. Grosch at Penn. Does anyone know of a Bluetooth enabled pumps controlled by smartphone?
I know people are talking about it. I don't know of one that exists in the world. Yeah,
I agree. I feel like I've heard about that that concept, but I haven't seen it in action. Right. Which brings up a different question, which is let's say you had a team of engineers and unlimited funds. What features would you like to see added into these pumps that you know, moonshot type stuff?
that you just said. So when someone says, oh, I've got it at rate X, I'm hitting my button regularly, I'm not getting what I want, I really would like to go to my phone and go, okay, hold it up to your microwave. Okay, now I've changed your rate and everything's fine. We should say the other thing going along with it, what's the great thing about it? The companies that allow you to have HIPAA protected data, patient data. I mean, from an academic standpoint, absolutely. But in private practice too, to be able to say, here's what patients say about us. Here's what they say about what we're, you can much more easily translate objective data and give that to people that, you know, the stakeholders that it really matters. I think that's an enormous part. When you say, what are the factors that are important for it? What else could you make it do?
Yeah, that's been a cool thing that, to be honest, we haven't leveraged all that much, but I know we could do a better job of is having that real-time patient data to say, oh, you know, so-and-so is pressing their button 3 times in the last hour. Let's give them a call and make sure that everything's
you said if you had a dashboard on your iPad, whatever it is that you come in the morning, everybody looks green, it looks fine. Oh wait, so-and-so's yellow and someone says red. Maybe I should go ahead and give him a call right now. Let's not let him end up in the emergency room because whatever, we didn't do a good job of educating him or something.
And that does exist. We just haven't made great use of it yet. Other questions. Does your pharmacy put the drugs in the bags? Do they compound the ropivacaine for you, or are you buying 500 ml bags or 1,000 ml bags of ropivacaine?
We're buying them.
Pre-filled, and we use 0.125 bupivacaine. We use a lot of local anesthetic, and that was like hundreds and thousands of dollars a year difference to go from ropivacaine to bupivacaine. But that's what they do, is they have them compounded outside.
Mm-hmm. And then with changing a 500 ml bag with an electric pump, are there concerns with resetting the pump? From Dr. Goldsmith.
No.
Not really. No, you just reset the volume to be infused, and then that that goes away. How about ambulatory stuff? What is important to patients at home if they're going home, leaving the hospital? What features of the pump are you talking to them about and saying, this is important for you to know about?
There's an 800 number that you can.
I was going to say, call the 800 number. Legit. I was going to say that.
Yes.
Yeah.
That's true, actually. Yeah, that hotline is a lifesaver, because they take care of most of those pump related calls, at least not medical stuff. But
right.
We're wrapping up here, and we have 5 minutes left, and I want to just cover a few more things. I'm going to play devil's advocate for a second and throw some shade on catheters and pumps. These comments I've heard people make. And so what would you say to this? Catheters are just too much work.
Peripheral IV is too much work. Why don't you just give them everything IM? It's the same. To me, that's the same thing. I know what those comments come from is, it's a lot of work. Not only did I got to do this, I got to put the thing, what if it leaks? And what if there's the calls? Let's say, you know, much trouble you got to go through to set up a laparoscopic gallbladder. Why don't you just cut them open and get the thing out? If you get organized in your processes and things, it's all about systems and organization. If you could do a block in 2 minutes, adding the catheter and whatnot for 2 more minutes. I mean, it's also sometimes it comes from people that takes 20 minutes to put a block in. So, I mean, putting the catheter in for another 3 minutes is sort of irrelevant, but.
Our surgeons also, some of them want to assess nerve function post-op, like some of the total shoulders. Our surgeons get really anxious if their arm is really numb, and like a adductor, the quad weakness. But that's the nice thing about not just doing a long-acting single shot block, because you don't have to worry about that. And I would worry about that. I mean, my brother had a lipoma taken off his shoulder and had a 3-day block, and he said, you could have cut my arm off. He hated it so much. And there's no ability to turn that off.
Right. That's right. You either have totally dead or totally off. To be able to modulate and move around, I mean, that's a better experience for everybody. You know, honestly, you know, Jeff, the whole thing about it's too much trouble. It's probably also too much trouble to, I don't know, watch your patient very, very closely, or to add a little bit of this, or honestly, you know,
I think your answer is a great one. I like that laparoscopic example. Yeah. We could take the time to do the right thing, or we could just, guys, we're in our last minute and a half here. I just want to ask you for any final tips, tricks, or parting wisdom for the audience about pumps and catheters. Leslie, anything you want to leave?
I mean, honestly, it takes a village, and you have to have really good education from the nurses and the patients, and the old people sometimes have a hard time with that stuff, but you really have to make sure somebody's engaged when you send them home. Because then you can create a whole set of problems if you don't have that.
Yeah. Right. And I think along those lines, you don't say, hey, let's start a continuous block program Monday. You don't do that. And you don't do everything for everybody. What you do is you get your best guys on just with one surgeon, with one surgery type, get a feel, figure out the problem, start with something that's in-house or something like this, and work out the kinks, get your system organized, and then build it out and build it out. Because the worst thing that will happen is you did a great college try the first time and something's not right. And the surgeon says, no, we're never doing that again. And again, start with the surgeon you have a good relationship. And again, what I say is, do you want to have have it stick, go to the surgeon and say, who do you have in them? Like I did the trauma, who do you having the most trouble with? Why don't I go try to work on that for you? And then suddenly you're answering their problems and you're making things better than they, incrementally moving along, I guess.
Yeah. Excellent advice, both of you. Listen, I think we could talk for another hour about this topic, the three of us. Unfortunately, Dr. Bublik did have an emergency with a patient. He couldn't join us, but I hope everything's okay. But I want to thank, again, Azra for putting this together, our sponsors, PAJUNK and Infutronics for supporting this. And thank all of you for joining us on a Thursday evening. It's been a lot of fun for me, and I hope for the panelists, and I hope for you too. So thanks very much, and we'll see you next time.
Bye.
Thanks, Jeff.